Caregiver Academy in Davie County. We are glad that you are with us. We're glad that we can continue to offer this service now in its virtual state beyond Davie County for those who may find these topics and conversations helpful. We are glad to welcome Dr. Caitlin Jones, who you'll be hearing from shortly. And Dr. Jones, I'd love for you to give give more of a bio later, but Dr. Jones works in internal medicine and geriatrics and brings just a wealth of knowledge to us as well. But before we get started, Annette Wheeler is unable to speak, but she is one of our care coordinators here at the Davie campus and will be with us for next month's presentation. So please join us for next month's Caregiver Academy. And then we have Angela and Shannon as well, if y'all want to introduce yourselves.
Hi, I'm Angela Nicholson, nurse case manager, community nurse educator. I forget who I am sometimes, but community nurse educator for Trellis Supportive Care. And today I am on the road, but I'm also one of the committee members, and so it's great to be able to have this venue and this platform. Thank you.
Wonderful.
And I'm Shannon Holland. I'm with Home Instead Senior Care, and we provide home care in Davidson County and Davie County, but we coordinate with other folks in the counties that surround that area as well.
Wonderful. Well, thank you. Just a reminder that we have one more Caregiver Academy for this year in December. And the last that I heard, we should have our 2021 schedule up and running by next month's time as well. Please do check the Best Health website. It will be posted there, and use the links to sign up as well. But without further ado, we'll turn it over to Dr. Jones.
It does say host disabled participant screen sharing.
So
sorry, should have tried this out earlier.
I said we've been doing this back since April. I didn't say we had perfected it. Make a co-host.
There we go.
Yes.
Okay. So my name is Caitlin Jones. I'm an assistant professor in internal medicine, and I am also a geriatrician. And so let's just get started on who is this new person. A disclaimer to start off with: this presentation is for information purposes only. It's not meant to diagnose, cure, treat, or mitigate, or prevent any type of disease or medical conditions. And if you have any specific questions about your individualized care, I certainly recommend that you speak to your healthcare provider. So the objectives today are: what is a geriatrician, normal aging and what we can do about it. I want to discuss normal versus abnormal cognitive changes with aging. I want to compare the different types of dementia and talk about caregiver communication a little bit and give you a community resource that you may not yet be aware of. So first off, I'll tell you a little bit about myself. So I'm originally from Georgia, and people become geriatricians for various different things. The reasons that I love geriatrics are twofold. One is that I love being around older adults, and I love the stories that they have to share. And then second, I love the complex chronic medical conditions that older adults have that include the polypharmacy and all these complicated medical issues. I find it very intellectually stimulating and challenging, and so very exciting. And so how does a person become a geriatrician? So it includes going to medical school and doing residency in either internal medicine or family medicine, and then at least a one-year clinical fellowship in geriatrics. And in geriatrics, we like to say that we focus on these 5 M's that you see here on the screen. So one is mind, which includes depression, dementia, and delirium. We also like to focus on mobility, so how you get around in your community and in your space, and how we preserve that mobility as you continue to age. Medications with specific focus on polypharmacy, which can mean a variety of things. My favorite definition is one more medication that you need. Multi-complexity, so that includes all of the chronic medical conditions that many of the older adults have. So diabetes, high blood pressure, high cholesterol, coronary artery disease, strokes. As you all know, the list goes on. And then the thumb is very important because it's what matters most. So it's focusing on those things that matter most to the individual, whether it's faith or family or a pain-free life or function, but making sure that we focus on what matters to the individual. And that's really what guides our care and guides our goals. So reasons you may want to consider seeing a geriatrician is if you suffer from multiple medical conditions, you find the treatment for one medical condition negatively affects a second condition, you're experiencing physical decline or physical frailty, you have a disease associated with aging like dementia, incontinence, or osteoporosis, or you're on multiple medications and often the side effects of one, like I said above, are adversely affecting your quality of life. So first, let's talk a little bit about normal aging and some of the things that we can make our normal aging more healthy. So starting with the cardiovascular system, as we age, our blood vessels stiffen, so the heart has to pump harder to work. That results in an increased workload. The heart rate also isn't able to increase as much during normal activity, and this leads to an increased risk of hypertension. So what can we do? So important is daily physical activity, and this doesn't have to be strenuous, high intensity. This can be just going for a little walk around the neighborhood. It can also be a healthy diet with fruits, vegetables, whole grains, high fiber foods, and lean proteins. So important that we manage our stress, because it's true that stress really does adversely affect our cardiac health, and this can be through meditation, exercise, and talk therapy. Sleeping is so important, 7 to 9 hours per night, as well as smoking cessation if you are a smoker. So next are the gastrointestinal changes. First, starting with the stomach. So the lining of the stomach has decreased ability to resist damage. So that leads to increased risk of peptic ulcer disease. It's also less elastic, so it can't expand as much, so it's not able to accommodate as much food as we were when we were younger. There's also a decreased rate of emptying into the small intestine. So small intestine, there's much more minor changes except for two that I do want to highlight. One is that the lactase levels actually decrease, so many older adults become intolerant of dairy products. And then second, some older adults experience excessive growth of certain bacteria that can lead to pain, bloating, and weight loss, as well as decreased absorption of certain nutrients. And last, focusing on the large intestine and the rectum. Certainly not glamorous, but constipation is truly an issue, especially as we age. And that's because there's slowed movement of the contents through the large intestine. There's decreased contraction of the rectum when it's filled with stool. And there's also the lifestyle contributions that worsen constipation as we age. So this includes dehydration, a low fiber diet, lack of exercise, use of drugs that can cause constipation. And some examples of these are narcotic pain medications, diuretics, and iron supplements. So what can we do to promote healthy aging with our gastrointestinal tract? This includes a high fiber diet with fruits, vegetables, whole grains, drinking sufficient water, physical activity, which truly does promote gut motility, and having a bowel movement when you need to have a bowel movement and not allow that constipation to worsen. So next is the aging genitourinary tract. So as we age, the bladder becomes less elastic, so you have to urinate more frequently. The bladder and pelvic floor muscles also become weaker, so that makes it difficult to empty the bladder, or you lose bladder control, and this is urinary incontinence. Additionally, men have an enlarged or inflamed prostate, so that leads to difficulty emptying the bladder and incontinence. Other factors that are associated with aging that make things more difficult include childbirth, being overweight, which increases the pressure on the bladder, and nerve damage from diabetes, as well as caffeine and alcohol consumption. So what can we do to promote healthy aging of the genitourinary tract? One is timed voiding. This is one of my favorite interventions. This actually means that you should put yourself on a schedule and you set a routine for going to the bathroom, so that you don't wait until your bladder becomes overly full and you can't make it. So I always start with 2-hour time mark, and you go to the bathroom every time you hit that 2 hours. Also maintaining a healthy weight, like we talked about, to decrease that external pressure on the bladder. Smoking cessation is always important. Kegel exercises, which help to improve pelvic floor function. Avoiding constipation and avoiding bladder irritants. This includes caffeine, acidic foods, alcohol, and carbonated beverages. Next, I'd like to talk about bones, joints, and muscles. So over time, the bones shrink in size and density, and this causes an increased fracture risk. The muscles lose strength, endurance, and flexibility, so this causes difficulty with coordination, stability, and balance. Additionally, fluids and cartilage that line the joints decrease and wear away with age, and this causes arthritis. So what can we do to promote healthy aging of our bones, joints, and muscles? One is daily physical activity. I know it sounds redundant, but it truly is so important for our bodies. This includes weight-bearing activity that can slow bone loss. Also, activities include walking, jogging, climbing stairs, and weight training. Avoiding substance use. This includes tobacco and alcohol products in excess. Calcium and vitamin D. Some dietary sources of calcium are dairy, broccoli, kale, salmon, and tofu. And vitamin D sources include tuna, sardines, egg yolks, and fortified foods. So it's important to talk to your doctor if you feel like you may need supplements for these important nutrients. So the next organ system I'd like to talk about is the skin. So with age, our skin thins and becomes less elastic. The fatty tissue below the skin also decreases, so bruising occurs more easily. As we age, our skin also becomes drier because there's decreased production of natural oils, and this causes wrinkles, age spots, and skin tags to become more common. So what can we do? You can bathe or shower in warm but not hot water. The hotter the water is, the more it dries your skin out. You can use mild soap and moisturizer. Also important to use sunscreen and protective clothing outdoors. Never too late for prevention and protection, and also smoking cessation if you are a smoker. Aging, vision, and hearing changes. So we may be living these firsthand, but difficulty focusing on close objects, difficulty adapting to different levels of light. If the lenses become clouded, and that's cataracts. As far as hearing goes, there's also increased difficulty in hearing high frequencies and difficulty following conversation in a crowded room. So what can you do? This includes following closely with your doctor and following that person's advice about glasses, contacts, and hearing aids, as well as continuing to take precautions. So using sunglasses and a wide-brimmed hat when outdoors, and protecting your ears with earplugs when you'll be around loud noises. Next, I'd like to talk about the aging teeth and gums. So as you age, oftentimes the gums pull back from the teeth. Elder adults often have a dry mouth that's worsened with medications. And these changes combined result in teeth and gums becoming more vulnerable to decay and infection. So what can we do to help promote healthy aging of the teeth and gums? So it's so important that we brush and floss regularly, as well as schedule regular checkups with our dentists. And last, I'd like to focus on the aging brain. So in general, aging should have minor effects on memory. This can include difficulty with familiar names or words and difficulty multitasking. And we'll go into this a little bit further later. So what can we do to promote healthy aging brains? One is physical activity in your daily routine. Physical activity increases your blood flow to the whole body, including the brain. It also helps to reduce stress and depression by having this daily physical activity. Eating a healthy diet with fruits, vegetables, whole grains, and lean meats, as well as avoiding excessive alcohol. In adults, we like to say, especially when older adults, the maximum recommended drink for a gentleman is 2 standard drinks, and then a woman, it would be 1. Next is staying mentally active. This includes reading, word games, new hobbies, continuing to engage in social activities as much as we can. I know COVID has made this all quite complicated, but socialization certainly helps to lower levels of depression and stress. Next is treating cardiovascular disease, and this includes managing the cardiovascular risk factors like high blood pressure, high cholesterol, and diabetes. And last but not least, one of the themes is to stop smoking if you are a smoker. So I'd like to just talk about a study quite quickly. There are many studies that show the same type of data, but I found this one quite interesting. So this is the healthy lifestyle and the risk of Alzheimer's dementia, and it was data pulled from 2 longitudinal studies published in Neurology 2020. So their objective was to quantify the impact of healthy lifestyle on the risk of Alzheimer's disease. So they pulled 2 longitudinal studies and for a population of 2,765. And then they defined a healthy lifestyle score, 1 point for each of these that I'm going to describe below. So non-smoking, greater than 150 minutes a week of moderate to vigorous intensity exercise, light to moderate alcohol consumption, a high quality Mediterranean DASH diet. So that combines the best of both worlds. So the Mediterranean diet, focusing on those Mediterranean foods with fruits and vegetables and nuts and olive oil, as well as the DASH diet, as well as engagement in late life cognitive activities. So in this study, they specifically described going to the library, reading books together, playing games that involve cognitive processes like checkers and chess. And then they followed these individuals for 6 years. As they followed these individuals, they found quite astounding findings of the association of dementia with these healthy lifestyle activities. So across these two cohorts, the risk of Alzheimer's disease was 37% lower in those with 2 or 3 healthy behaviors and 60% lower in those with 4 or 5 healthy behaviors. So pretty convincing evidence for me that healthy lifestyle factors certainly do decrease our risk of Alzheimer's disease. There are many studies of this type going on. In fact, there's one clinical trial that's starting at Wake Forest that has a very similar concept called the Pointer Study that's focusing on these healthy lifestyle interventions and reducing our risk for developing Alzheimer's disease. So next, I want to talk about normal aging versus dementia in a little bit more depth. So I'm going to focus on possible changes of each side. So again, these are very much possible changes, certainly not diagnostic, but maybe something that may bring up some questions in your mind. So when we talk about short-term memory, normal aging, people sometimes forget names or appointments, but remember them later. In the setting of dementia, though, you may forget names of close family or friends, or forget recent events, like if you had a visitor come to see you that day. Normal aging, you occasionally forget something you were told, but possible dementia, you ask the same information over and over and over and over. Normal aging, we may misplace things from time to time, but then we can retrace our steps and find things again. However, in possible dementia, you may put objects in unusual places, like putting your house keys in a bathroom cabinet. Or for example, I saw a lady in my clinic who would always lose her checkbook, and then she would find it actually in her clothes that she'd ruffled around and put in her clothes drawers. So next, we'll talk a little bit about planning, problem solving, and decision making. So possible changes due to normal aging include being a little slower to react or think things through. Possible dementia includes getting very confused when planning to do things. Possible changes from normal aging is less able to juggle multiple tasks, especially when you're distracted. Possible dementia means having a lot of difficulty concentrating and not even able to complete a task or even plan a task. Normal aging includes making bad decisions once in a while. Possible dementia includes frequent poor judgment, especially when dealing with money or assessing risk of a situation. Normal aging means occasionally make a mistake when managing finances. Possible dementia means having trouble keeping track of your monthly bills. The next domain I'd like to talk about is language. So normal aging means occasional difficulty finding the right word, whereas dementia has frequent problems finding the right words or referring to objects as that thing over and over and over. Normal aging includes difficulty concentrating to keep up with the conversation, whereas possible dementia is having trouble following a conversation or joining in. Normal aging, you may lose the thread if distracted or if many people are talking at once, but possible dementia means regularly losing the thread of what someone is saying. Next domain is orientation. So with normal aging, you may get confused about the day of the week, but then figure it out later. But possible dementia means losing track of the date, season, and the passage of time completely. Normal aging, you may go into a room and forget what you were doing, but then you remember again later. However, possible dementia means going into a room and getting lost and not knowing where you are, even when you're in a familiar place. Next domain is mood and behavior. Normal aging is sometimes being weary of work, family, and social obligations. But with dementia, people often become withdrawn or lose interest in work, socializing, and hobbies. In normal aging, sometimes people feel a bit low or anxious, but with possible dementia, getting sad, anxious, or frightened, or having low self-confidence. And last, with normal aging, you develop a specific way of doing things and you become irritable when your routine is disrupted. Possible dementia includes becoming irritable or easily upset at home, at work, with friends, or uncomfortable or familiar places. And I just do want to emphasize that, yes, depression can present as a separate entity, but oftentimes severe or uncontrolled depression may be an early sign of dementia, just something that we all need to be aware of. So conditions that can mimic dementia, number one, I already talked about depression. Also is hypothyroidism, so low thyroid. normal pressure hydrocephalus, so that's extra fluid on the brain, infections, especially those that affect the brain and the spinal cord, but any systemic infection can appear like dementia. Vitamin B12 deficiency and some medication side effects can also mimic dementia. And when I say dementia, it's actually a very much umbrella term. So many different conditions can cause dementia. So I think Alzheimer's disease, vascular dementia, frontotemporal dementia, Lewy body dementia, Parkinson's disease, alcohol abuse over the long term, having a brain tumor or a subdural hematoma, having an injury to your brain, having lack of oxygen to your brain, having prolonged hypoglycemia, certain infections like syphilis and HIV, when present for a long period of time, can all present as dementia. When I say this umbrella term, clinically, when you actually find dementia, I would define it as memory impairment that affects function. So what do I say when I mean function? When I talk about function, I'm talking about ADLs, which are activities of daily living, and IADLs, which are instrumental activities of daily living. So ADLs, we like to say, are things that a kindergartner can do. So they're feeding it and feeding yourself, dressing yourself, bathing yourself, going to the toilet by yourself, and transferring yourself from the supine to the sitting to the standing position. IADLs are those instrumental activities of daily living. These are more complex tasks. These include medication management. As you know, older adults are often on many medications, and having these on the correct schedule and taking them at the correct time with the correct dose is a pretty complicated task. Transportation, managing finances, shopping, cooking, telephone use, and housekeeping. And generally with dementia, we first see loss of these IADLs in the earlier stages, and over time progress to loss of the ADLs. So loss of one of these functions clinically is how I would define dementia, and it's loss of these functions due to memory impairment, not because of a physical impairment. For example, if someone has an injury like a hip replacement, and so they now have difficulty driving, that wouldn't be definitive of dementia. It would be someone who literally can't remember what their medication is and what time they take it. That's what I would define as dementia, loss of function due to memory issues. So next, how do we diagnose dementia? So first, there's a comprehensive history, and it's very important as a clinician that I have history from both the patient and the caregiver. I find that collateral history is so key. It often gives us a lot of really important information that we need. Also, a detailed physical examination, looking often for signs of stroke or weakness on one side, cognitive testing, and there's a whole battery of cognitive tests that we perform. Laboratory studies, so expect to have a blood draw, as well as brain imaging, often an MRI, so we can get a really detailed look of the brain. So I'd like to talk a little bit about the 4 most common types of dementia. And these we're going to talk through are Alzheimer's disease, Lewy body dementia, vascular dementia, frontotemporal dementia. So first is, I'd like to talk about MCI actually. MCI is mild cognitive impairment. Its cognitive decline is reported by the patient, a knowledgeable informant, or observed by the clinician and documented by formal or informal neuropsychological testing. And very important distinction between cognitive impairment and dementia is that cognitive impairment does not interfere with independence and everyday activity, so it's not a loss of function. So now we'll go through these 4 most common types of dementia. So first is Alzheimer's disease. It's the most common type of dementia, and at least 60% of dementia cases are due to Alzheimer's disease. Often more common in women than in men. Presents with short-term memory loss, difficulty with problem solving or planning, trouble with visual spatial relationships, so you may see difficulty driving, looking out for things like scraped side of the car or a mirror blown off the car, language and trouble following conversations, withdrawal from social activities. And the progression is very chronic, slowly progressive disease. So initially, as I was talking about, there's difficulty with the complex tasks, those IADLs, but eventually trouble with self-care activities and those ADLs. The prognosis, so there's several treatments like donepezil and memantine that slow the progression and manage symptoms, but I wouldn't necessarily call them a cure. I would more so say that they're for slowing and managing these symptoms. Usually, Alzheimer's disease lasts for about 8 to 12 years, but many individuals do survive longer than this. Next is Lewy body dementia. So it's about 10 to 15% of dementia cases, and it's more common in men than in women. This is a very interesting presentation that includes confusion that changes from day to day. Often individuals with Lewy body dementia have hallucinations, and specifically these hallucinations are of small children and animals. Also, there's sleep disorders where people act out their dreams. So for example, it may appear like PTSD, where a person dreams about being in a war or being in a fight, and they wake up fighting and punching. It's also related as the disease progresses, they have Parkinsonian features. So they have slower gait, so slower way that they walk, and very stiff muscles. With progression, the memory loss is less severe in early disease, but worsens over time. And like I said, those movement disorders are very troubling because they do lead to falls and balance issues. As far as prognosis, it shortens longevity with the average lifespan of 5 to 7 years after diagnosis, but it's much more variable than Alzheimer's disease in general. Next, we'll talk a little bit about vascular dementia. So it's responsible for about 10 to 15% of dementia cases, but it's often present alongside Alzheimer's disease. So you have a combination of both Alzheimer's disease and vascular dementia, more common in men and more common in individuals with high blood pressure. It's due to inadequate blood flow to the brain, usually from a stroke, and presentation depends on what part of the brain is affected by the stroke. The progression is stepwise rather than gradual like we see in Alzheimer's disease, and that means so that the person has a stroke, we see their function decline, and then they reach a new baseline, and then they'll stay at that baseline, and then heaven forbid you have another stroke or another insult to the brain, and then we see another decline in function, which will again stabilize over time. The prognosis is very important to reduce risk factors that further brain damage, so smoking cessation, controlling blood pressure, diabetes and cholesterol, eating a healthy diet, and exercising. And then we'll also talk about frontotemporal dementia. So it's the least common type, and it's less than 5% of the cases. There's two main subtypes of frontotemporal dementia. There is a behavioral variant and a language variant, and men and women are equally affected. So the behavioral variant often presents quite early as age 50. And I look at it as losing a person's filter. So you lose your judgment and your empathy and often act in ways that we find socially inappropriate and are very out of line and out of character in the way a person previously would have acted. And second, there's the language variant. So these individuals lose language skills and have difficulty speaking, writing, and understanding conversations. So the progression is a slow decline over time, and the rate of change varies from person to person. Unfortunately, no medications have been shown to help. Often starts with behavior and speech problems, then memory is involved later in later stages of the disease. And the prognosis, average life expectancy is unfortunately 6 to 10 years after a diagnosis of frontotemporal dementia. So next and finally, I want to talk a little bit about caregivers. As you all know, caregivers are just key to support of those people who do have cognitive impairment. And so I just want to emphasize that dementia is a disease that affects the entire family. And more than 70% of patients with Alzheimer's disease are cared for at home, typically by a family member. And just some really impressive statistics. In 2013, caregivers spent an average of 1,139 hours per week, hours per year, so 21.9 hours per week providing direct care for patients. So that's, at least a half-time job in addition to many of these individuals also having a full-time job out of work. And so in 2013, 15.5 million American families and other unpaid caregivers provided an estimated 17.7 billion hours of care, which is equivalent to $220 billion. So as you're talking with your provider, I want you to know that providers understand as much as we can. We're certainly not living in your shoes, but we've worked through this before with multiple people, and we understand the difficult job that you're undertaking. And like I said, dementia is a disease that affects the entire family. It's not just the person, the individual who has that disease, but all the people involved. And so it's best treated as a partnership between the patient, the caregiver, and the clinician. And the treatment of dementia involves treating, supporting, and educating the caregiver along with the patient. So I would encourage you to work closely with your primary care provider because they should be able to provide you expectations with progression of disease. And because they've worked through this disease process before with other individuals and their families, they should be able to give you cues as to when they expect things may be changing and help to guide those transitions as you're working together. The resource I wanted to talk about is the Wake Forest Memory Counseling Program. It offers two very important services. One is counseling services with supportive psychotherapy, solution-focused therapy, and cognitive behavioral intervention and strategies. They also have a variety of support groups. And as you know, support groups are so key for working with a person who has memory difficulty. So they have support groups both for the caregivers and for those individuals who have early dementia, as well as they have groups to help care for those who have dementia while all their care partners are working with the support groups. So just something for you to consider and to look into if you weren't already aware. So these are some references that I used, and that was what I had prepared for you today. So thank you again.
Thank you so much.
You're welcome.
Your presentation. I want to open the floor for questions. And I've got a couple too, but Shannon, looks like you unmuted. Would you like to get us started?
Well, I was wanting to take a screenshot, or I was going to take a picture of the resources that you had, the support groups. And
of course.
It disappeared on me, so perhaps we can get that. I think that would be a really good tool, link, etc., that we could provide when we send this link out.
Let me get it in.
Great idea.
Okay.
So Adam, I will either attach it as a picture or.
Excellent. I think that'd be great.
Yeah, I do too.
Dr. Jones, I had two questions for you. The one, pardon the pun, but is the age-old question of when is old? You know, I mean, so it seems like dementia has a certain time age range that it appears. What about some of the ways that our gastrointestinal and cardiovascular health? When do we really classify some of these changes as aging related?
That is an excellent question, and that is such an interesting question too, because as you said, aging is so heterogeneous. We all age so differently, and there are 90-year-olds who appear, you know, in their hundreds, and there are some 90-year-olds who look like they're 70. So physiologically, we start aging actually in our 30s. Some people would even say that, you know, we start aging as soon as we're born. But from a physiological standpoint, for example, you start seeing decline in your kidney function in your 30s. Many of the other changes I talked about, like the changes in the bladder, for example, you see as you get older, I would say more so in the 70s and upper 60s, depending on what other comorbid conditions that you have. But yes, aging starts when you're quite young, as we know, and you start seeing those physiological changes, generally 65 or so. Earlier, later, we are all very individual.
Excellent. As a 31-year-old, you just brightened my day. Thank you.
Adam, I would say my non-clinical answer to that question would be 40 is when it all breaks loose. And then when you hit 50, you really don't care anymore. So whatever's now falling apart, you're like, I'm good. So you got 40, and then you'll be all right when you breeze to 50.
That makes sense too. Two other quick questions for you. Let's start with this one. When is it, so is that 60 to 65 range the best time for caregivers to maybe encourage their care recipients to seek a geriatrician? When is that best transition from a primary care to a geriatric specialist? What does that transition look like?
So it can happen in multiple ways, I would say. There's some, like you alluded to, who are very high functioning individuals who certainly should continue to follow with their primary care provider who they have a very close relationship with. Then there may be other individuals who have some of those specific questions about polypharmacy issue or these multi-complexity issues questions that they have. So then they may want to have a consultation with the geriatrician and continue to follow with their primary care doctor who they already have a really good, solid, long-standing relationship with. And then there may be that third group of people who have very advanced dementia and truly need a different level of care. And that may be a good person for a geriatrician to follow specifically, because I also think geriatricians are skilled at being the navigators through the system and really helping to coordinate the care and make sure we focus on just what matters most and focusing on quality of life for that individual, whatever that looks like within your care goals.
Excellent, thank you. How about from Shannon, Angela, Annette, anything from you all?
I have no questions. I just found the presentation very informative, very interesting. Thank you.
Thank you.
Excellent, excellent.
It has also sparked me to make that suggestion when someone, and I'm actually thinking in my family as well, when somebody has a primary care physician that they've had and hold on to as their only source of information, even though you see that they need an additional perspective, to consider that gerontology route for a more focused, for more focused treatment on that specialty of an area. Oh, I think we have another question here. Let me check. Oh, and it says no questions, but thank you, Caitlin.
I have one more for you, if you don't mind. No, the Stick Center was working on a study. It's probably been a year or so ago now, around dance and intentional movement and either dementia or Alzheimer's. I'm not sure the exact parameters of it, but is there any? I notice exercise and non-smoking were almost in everything, but is that link being proven that there's some link between our intentional movement and dementia at this time?
Absolutely. I can't tell you the results of that study. I believe Christina Soriano and Christina Hugenschmidt were working on it, and they were working both with the individuals who have memory impairment as well as their care partners.
Mm-hmm.
But yes, they found that it really was helpful with progression of symptoms, especially stress. They also found that it was very much improving in their stress burdens. I don't know the results yet of that, but it was a very exciting study.
More to come then.
More to come.
Glad to hear that. Especially in the midst of COVID, I'm glad they could get that study up and running and moving. So wonderful, wonderful. Thank you so much for being with us today. We are so glad that you're here. So glad that you work with the patients that you work with. You're just such a blessing to our system and to our community. So thank you for that. And for everybody who's joining us online, we are glad that you're here. We are here to support you in any way that we can. And we ask you to please reach out to us if there's any way that we can be of assistance between our monthly gatherings. But if not, I hope you all have a happy Thanksgiving, and we will see you in December. Take care.
Thank you.
Thank you, Dr. Jones.
Thank you.
All right, take care.